what if your next compliance crisis is already happening, but you just don't know it yet? Today, Ross sits down with John Moses, founder of Northgate Healthcare Advisors, with over 30 years in senior healthcare leadership. John's become a trusted, strategic partner to CEOs and CMOs nationwide, helping them navigate their most complex clinical compliance challenges. In this eye-opening conversation, John shares how one spine surgeon triggered 28 lawsuits before anyone intervened, revealing why compliance silos are every organization's biggest vulnerability. Ross and John explore the real ROI of compliance investment, personal liability risks for board members, and the critical difference between coding compliance and clinical necessity that could cost you millions. This episode delivers the systemic approach healthcare leaders need to transform compliance from a feared department into their strategic advantage.
Welcome to the Compliance Advantage podcast. This is where healthcare executives transform compliance from a burden into a strategic asset that drives both growth and peace of mind. I'm your host, Ross Ronan, founder of Ronan Healthcare Compliance and a healthcare compliance strategist with nearly 30 years of industry experience. I'll help you stay ahead of evolving regulations while building the sustainable, compliant organization that lets you focus on high-level strategy and exceptional patient outcomes. Remember, compliance pays dividends. Invest today. Welcome, John Moses, to the Compliance Advantage. Thanks for coming over today.
Nice to be here. Nice to be in downtown Denver.
That's great. Now, we got introduced not too long ago through, I think that's your firm joined with Coker, and we had some relationships with Coker, and they put us in contact with you to just have an introduction. And since that time period where we had a conversation, I think we clicked and hit it off right off the bat. And the stuff that you do and the stuff that we do overlaps a little bit. So tell us a little bit about what you do and how you got into this.
It's interesting how people in the compliance world click from different perspectives.
Absolutely.
My background's hospital administration. I was trained as a hospital administrator, spent the first half of my career, which is a long career now. I think I'm over 40 years. Even though I look great, I'm really pretty old. But first half in hospital leadership, including some time as a CEO, and then left that to move into the consulting world. After running the nation's first concierge medicine program called MD Squared, that was quite an experience. Healthcare for the ultra wealthy, moved into my own consulting world, where we worked on solving a lot of the problems that I experienced when I was within the walls of hospitals. Specifically, how you evaluate the care provided by physicians and clinical programs in a credible, objective, thorough way that feeds leadership with the decision support it needs to make very important decisions. So that's really what I've been doing for the past 20 plus years.
Okay. And that's what's the firm's name? Northgate, right?
Northgate Healthcare Advisors, now a Coker company.
And tell me a little bit about kind of what it does and its overarching mission.
Yeah. So if it's a clinical question, we're likely well suited to answer it. Northgate is based here in Denver, although thanks to COVID, we're now spread out all over the place, including as far away as New Zealand, where our focus and our foundation has been physician peer review, working for medical staffs of hospitals. Now, that's compliance.
Sure.
Okay. Believe it or not, it's in a silo, but it's compliance.
101.
But what we've done is taken that. So what that was is any time a physician's care comes into question in some way, or there's some blip on the radar, say returns to surgery or higher than expected mortality rates, or it's a new program and we just want to evaluate, make sure things are going well, or we just want reconnaissance for the only neurosurgeon, say we have. We are called upon by hospitals in every state of every shape and size to answer questions like, should we have the confidence and trust in this physician? That's the classic physician peer as we know it, working for medical staffs. But what we've done is layered on top of that other answers to questions like, should we defend ourselves against this payment denial? Should we defend ourselves or settle this medical malpractice claim? Is the care being provided by our physicians necessary and appropriate, i.e. devoid of fraud and abuse? And I think that's what we'll probably spend a fair amount of time talking about here this morning. We have a clinical crisis in our midst, and there have been some very prominent national stories that we've been in the middle of albeit in the background, not so publicly. That's the way these things work. And helping hospitals navigate those waters, identify how they got to where they are, usually very preventable, and then how they right the ship. So we spend a fair amount of time on site with our clients in very deep consulting engagements, which almost always start at the micro but expand to the macro, organizational leadership and governance.
And you have a number of clinicians on your panel or your kind of group of people that you employ, work with, or help you do those. How many are those now?
Yeah, we're over 300 physicians, all specialties and subspecialties, different backgrounds. And I say subspecialties because a cardiologist, as we know, is not a cardiologist. We have electrophysiology, and we have interventional, we have structural, and we have transplant cardiology, and so much more. So we are very specialized. When you review cases for any reason, you have to have the credibility and the defensibility of the decision support we provide. So they're all over the place. And like our clients, they're from the largest teaching centers and healthcare systems to the community hospitals and group practices, all the way down to critical access hospitals. Right. So everything in between. And more, our work is coming directly from the attorneys who serve those hospitals, many of whom are already our clients. So it's a great team of physicians that we're really blessed to be able to have and work with, all of whom have come to us through referrals from people we know and trust.
When we started talking in the first place, there's such a yin and yang with what we do and what you guys do, because we're compliance on the regulatory based side of it. That's very OIG, 7 elements, following the patterns. And how do you refund? How do you do the actual of taking the money and giving it back and all those things? And one thing that we always are looking for or missing a little bit is, was that medically necessary? Was that because only doctors can tell other doctors whether or not something should be the scope of practice, within whether it's medically necessary or whether it should have been done this way or this test should have been ordered. And so it's such a well-rounded compliance discussion that we're going to have today with kind of the regulatory compliance and then the clinical compliance and how you marry them up and how does it really enhance healthcare and really reduce fraud, waste, and abuse.
It's interesting to me what a monster that we've created with this healthcare system. It is such a game. And so the whole notion, for example, of coding, there's a tremendous incentive to upcode or to code for the optimal reimbursement, to code for things that even weren't done, because that really is what drives the invoice or the bill, and it's what drives the reimbursement. And so we spend a lot of time looking at those codes, and there's a lot of coding fraud and abuse exacerbated by the simple fact that the profit margins made by those in healthcare, be they hospitals, physicians, other providers, other entities within healthcare, those margins have shrunk. So we put the pressure more and more on people like physicians to do more, to earn more. And so what we see in contracts is this coming together of physicians, say, in hospitals where they're challenged to earn as many work RVUs as they possibly can. And what we see on our side is the fallout from that, because the more you do, the less time you have to think into care, the more motivated you are sometimes to do unnecessary things. Now, I think it's still a very small percentage of healthcare, but it's way more than most people realize, this rampant fraud and abuse. And so what we see on our end is the mess that's created that could be prevented, but the mess that's created by unnecessary care that has flown under the radar and results in massive returns of reimbursement, treble damages, penalties, and some of which completely devastate a hospital and a physician's career and practice.
Yeah, I think it was like $3 billion last year that the OIG recovered, DOJ recovered from healthcare providers under fraud, waste, and abuse. And that's a lot of money. You want to talk about putting money back into the federal healthcare program, it's $3 billion.
It's crazy. And since the beginning, I think we're up to 50 to 75 billion. It's an amazing amount of money.
Well, you've done this for a really long time, right? And 20 years. When you walk into a CEO's office or you get called, you get tapped on the shoulder, right? Whether GC, CEO, whoever, board comes in and says, okay, look, compliance is just a burden we have to bear because it's just a necessary evil. They tell us we need it, clinical compliance, whatever it may be. What is that conversation? How do you have that conversation with that CEO to say, look, you need to do more? And it's not just a burden you have to bear. It is a way of life. Set it and forget it. Put it in your budget and forget it. As a hospital CEO, you know this. And then how do you have that conversation?
We could stop there and talk for hours on this subject, but I'm going to just
you
try
don't.
to
You
say
have
it.
3 minutes.
Okay. All right. I'll take 4.
Okay, deal.
What we have is a really complex situation again, where fear, first of all, is a powerful motivator. And believe me, I have stories to tell.
Sure.
And I could even direct people to articles to read of these real stories where we found ourselves directly in the middle of all of it. And yeah, it's a pain, as is a lot of stuff in healthcare and hospitals. Mm-hmm. It is an expense, but it is an investment, because it's an investment in a way to retain the money that you've earned. Some of it, which probably shouldn't have been earned, but it's a way to also get on top of those things so that you minimize the damage if there is any, or even better, you can prevent these things from happening in the first place. Compliance isn't just identifying problems, it's ongoing reconnaissance to make sure that these things are identified early, that there are measures of prevention in place, which are very powerful. For example, compliance programs that just promote themselves within their own organization. Effective compliance programs can do a whole lot to keep people from crossing the line. And I always said hand washing still is not great in hospitals as a hand washing rate, but put somebody, say a nun, in the back of the bathroom with a rule in her hand, and everybody's going to wash their hands. And there's a push and a pull to that. But I think that CEO that I'm talking to and telling the stories to, there's not just the money side, there's the human side.
Sure.
Because at the root of every one of these situations, described in every medical record we review, at the core of every code that results in reimbursement, there's a patient, there's a family. It's the business that we're in. We're not in the business of making money. We're in the business of providing care to patients. And that's where Northgate and Coker really jump in. But if I could just add one other layer to this, and I hate to say this about my colleagues in hospital administration, many are not trained in this area.
Of course.
Many of them don't understand it. And what they don't understand, they don't lead, they don't address. And I'm always shaken by the fact that hospital administrators, to be a nursing home administrator, you have to have a license.
Sure.
To be a physical therapist or an occupational therapy assistant or a physician, you have to have a license in the state.
Right.
Hospital administrators are not required to have a license. And therefore, we have people, and I would say all over the continuum, all across the continuum in terms of their levels of knowledge, their ability to surround themselves with people who can cover the things they may not know, important art of leadership. And so a core there for their expertise. They should be the expert in their organization, and therefore they should be the ones to teach their board how to hold themselves and the rest of the people in that organization accountable. So it's not just the CEO.
Right.
It's the board, who are from finance and who are from car dealerships and who are from wherever.
Right.
They know their way around a P&L, but they come into this situation at great personal risk and great risk to their community, covering that great risk, and they don't understand compliance because nobody teaches them that and other important elements of governance and leadership.
Yeah, board training is huge, right? And the CEO always sits on the board, and when you have a conversation, we do a lot of board training, and most of the time we do it complimentary, because for the exact reason you just said, the word has to get out. The word has to understand what it means, what your liability is. When we talk about investments as Ronan, we have 3 Ps, right? It's protecting profits, it's the preferred partner status, and it's also patient trust equity. And those are 3 Ps and pillars. And I've got a story behind each one of those of what that ROI is and how we got there. Do you have an ROI story that you tell them? That you're just like, hey, let me tell you. I had this happen this time, and let me tell you what it is.
So you asked me the question, and my head swims with stories. I'll just tell you one that popped into my head. We received a call, and this was from actually a hospital medical staff leadership.
Okay.
It was a chief medical officer in conjunction with the chief of surgery. And their problem was they had now been served 28 lawsuits by an attorney who caught wind of these challenges. And what was happening is people were being harmed. And this was a lone spine surgeon who had just come out of fellowship. The CEO and the board saw a revenue stream, got very excited about this. They thought about the reputational wonder of now we do spine surgery. And first of all, 28 lawsuits, you wonder, how did we get that far?
That's a little bit of a pattern.
That's a pattern. And then when we looked at the cases, a large percentage of them were unnecessary surgeries. So you talk about a mess. Now, because you have the lawsuits.
Sure.
Each one did settle for a lot of money.
Yep.
And you have the compliance, which did result in self-disclosure and repayment extrapolation across this. It wasn't a full 6 years because the guy wasn't there 6 years,
thank
but
God.
from the very beginning. And what could have done to prevent all that?
Yeah.
And so I'm talking to a CEO and I'm saying, and that CEO, I'm saying, this is all preventable. This could have been prevented by having a compliance program that was effective, that taught your board how to pay attention to this stuff, that made sure your CEO was well aware of these opportunities. So what could you have done? You could have, especially for a new program, gotten the help of an outside firm like Northgate to watch these cases. You could have had internal expertise, know the national coverage determination, local coverage determinations, perhaps standards associated with necessity for these procedures. That could have been a very important part of compliance. You could have maybe had a virtual proctor for this new physician who was coming out of school, who his career is devastated because he didn't have the support. You could have known better, in my opinion, than to have a new fellowship trained surgeon come out with no mentor, no support, no nothing. And then on the medical staff side, you saw the complications, but you didn't deal with them. Or did you have the mechanisms in place to identify or track these complications? It should have been stopped, in my opinion, at the front door. But important here are that the medical staff not doing its job is in a silo. Compliance is doing its job or not in a silo. Quality, risk management, all of these folks are working in silos. And if they would just get together once a week and have coffee, and I know there are laws that help create these walls. If they would talk, they would learn a lot from each other and be able to head these things off a whole lot earlier. I love the fact that you're doing the education. That's where it starts. I think it starts in medical school. It starts in the boardroom when board members first come on to as part of their orientation. It starts with hospital administrator training, and I would dare say licensing is an important piece of this. But your education is critical because we have to start somewhere, and we're not doing enough of that important part of leadership competence.
I think you hit the nail on the head. I read a statistic a while back that said every $1 you spend on compliance saves you about $6 in legal fees associated with civil monetary penalties, lawsuits, et cetera, et cetera. And that really plays out in your scenario that you're talking about. 3 cases is a pattern, not 28 is a bigger pattern than you should have caught it at 3 or 4 lawsuits that come through. Somebody's light should have went on to say one. One. I feel like one does not a trend make, right? But at least 3 do. So
it depends on what the one is about.
That's true. It's true. It should be investigated to the root cause for sure. But I think that really does, for all the CEOs and the board members who listen to our podcast, I think that's really important to go. The ROI really is preventing these things from happening. And I've had conversations with CEOs a lot, and they always say, what's the ROI? What's the ROI? And I've got lots of ROI stories like you too. But one of the things is always, how do you prevent a negative? How do you prove a negative? How do you prove something didn't happen because you were so good that you prevented it or mitigated it? And so it always comes after something bad has happened so that they can prove that ROI.
That's right. One other quick ROI story. I'm working with a hospital now that is maybe small to mid-size. And by that, I mean in the 200 plus bed range. And they asked for our help to identify or to address what they thought was a compliance concern. We evaluated, and what we found is you're actually in good shape. What you have is an IT issue here. Topic for another day. But what we did find is that there were other issues that they needed to be aware of. One thing led to another, and they are now in this difficult situation of self-disclosure with more money than they have. Okay. And that's if it goes well. I mean, the fact that they got there tells you that they have a very weak compliance program, which the feds tend not to look kindly upon.
No.
And that place is, talk about an ROI, is in a fight for its life.
Yeah. That's a dangerous place to be. Yeah. Now, dovetailing into that conversation of the essential pieces of a clinical compliance program or just a regulatory compliance program, however you want to define it. I know you come with a very systematic approach to what you do in your business at Northgate. What are your kind of advice on your non-negotiable essential items that you should have within an organization for, let's just say, clinical compliance, where you're making sure, I think you talked a little bit about MSO needs to do their job and everybody needs to be talking to each other. What are those kind of non-negotiables that you would recommend for everybody to take away?
A lot of my work looks to find the root cause of problems. And those are where the opportunities are to prevent problems. It also reminds me how to become a millionaire, first get $1 million. Compliance leaders need to be selected based on key criteria against which they're measured. And the people making those selections, like I said earlier, unfortunately don't know those key criteria. So number one is educate yourself as to what you need in a compliance leader. I bet your education that you provide to boards and CEOs can go a long way towards helping people do that. But let's look at what some of those criteria should be, because that's one of the key issues. You've got to have a competent leader who views compliance not as cybersecurity only or as HIPAA violations or as whatever the concern of the day is, but comprehensively, including clinical. It's why when we do get involved in due diligence for mergers and acquisitions for maybe your M&A audience, we've coined a new idea, and it's taken off like crazy. As part of the due diligence process is to look at whether or not you have any fraud and abuse or other quality risk. Know what you're buying. Like you want to know what you're buying, you want to know what you have.
Sure.
And so from a compliance standpoint, it's got to be comprehensive. The compliance leader has to be free to communicate with the board on a regular basis. I would dare say you want to pick somebody who will educate the board as to what the risks are in general across healthcare. But here, these are our concerns. This is what's on our radar. These are our future initiatives. This is what we found. This is our current crisis and what we're doing about it. There has to be a direct line without interference from anybody else, so that person can freely and objectively allow the board to do its job. All right. And not sweep it under the rug because it might make me, the CEO, look bad. Okay. If I did my job in the first place, I'd be embracing the challenge like everybody else, and maybe the challenge wouldn't be there. That to me is a very critical piece. One other, and there are several, is work across the silos. Don't view compliance as your own department. Compliance is organization-wide. It's medical staff, it's quality, it's risk. If those folks are talking over coffee or whatever else it might be, they're going to learn a lot from each other. It's hard to get information out of the medical staff because of concern for breach of the peer review privilege. Yep. But there are ways to do it. There are clear ways to do it. Talk to your lawyers. Yep. Talk to your counsel about how to do it. Don't assume that you can't. So these are just a few ideas.
This episode of the Compliance Advantage podcast is brought to you by Ronan Healthcare Compliance. At Ronan Healthcare Compliance, we believe in transforming healthcare compliance from a checkbox attitude to a strategic advantage. With decades of expertise, our team of consultants provides innovative solutions tailored to your organization's unique needs. We don't just help you meet your standards. We elevate your business, ensuring ethical practices are at the heart of what you do. Whether you're navigating complex regulations or seeking to enhance your compliance strategy, Ronan Healthcare Compliance is your partner in achieving excellence in healthcare compliance. Ronan Healthcare Compliance, redefining compliance, empowering leadership. Visit us at ronanhc.com to learn more. Now, back to the show.
The essential of compliance leadership is imperative to really an effective compliance functionality, not necessarily just the department itself. Like you said, compliance is a thing. It's a feeling, it's a mantra, it's a culture. And it just so happens there has to be someone who manages it and runs it. And one of our philosophies is also the compliance, we call them compliance executives, not compliance officers, because the people that we help and we create and we talk to are one step above that. They become not the CFO, they become how do you get to this next stage? And they become that strategic partner. We also call them the steady partner, and steady is an acronym that we'll go into another time on that. But that steady partner really becomes that strategic person, like you said, who educates the board, educates the CEO, educates its peers, his or her peers of risk management, quality, medical staff office, general counsel's office, whatever, so that you are collaborating and creating that culture of compliance. And I think 100% non-negotiable on one of the essential pieces is having that leadership functionality. Do you see, is there any kind of thought about having quality review committees and things like that within a hospital system or within a group practice? And I don't want to get into the legalities of that and all the MPPD and all that kind of stuff, but is there a value in that, in A? And B, is there a value in having the compliance executive sit on those and participate?
I think that's essential too. Compliance has a bad rap.
Of course.
They're feared in these organizations. Here she comes. Oh boy. And that's because much of what compliance is perceived as is reaction to a perceived problem. Mm-hmm. And what you get to that is, it wasn't me. I didn't do it. Leave me alone. Just let me do my job. It's shunned and feared instead of embraced. And it should be embraced because it's an opportunity for everybody. We work with one of the largest healthcare systems in the country, and we help them to build a reconnaissance program with compliance very much at the helm. But what compliance is doing is getting the word out that we're in this together. And as a result of being in it together, we're putting in place, by the way, on our dime is the system to protect ourselves and to protect you. And here's how it's going to work. And it's a playbook. That playbook is promoted. And you know what? It's one of the greatest preventers of fraud and abuse, just by promoting and having the savvy to say, we're in this together. Here's why we're doing it. The laws that are in play. Let me tell you some stories. Making a case for change, which is so much about leadership. We can't do nothing.
Right.
We can't stay in this situation. We have to get ourselves always to a better place. And here's our roadmap for getting there. When that is understood in organizations, it's far more likely to be embraced by everybody involved. It's more of a thank you than get out of here.
Sure.
And so back to leadership. That's non-negotiable, to have a leader that you can select that can not only creatively build these programs, be a part of the quality committees, maybe even have a line to the medical staff or even serve on medical staff, key medical staff committees, because you've got to have a broad view, but also somebody who can communicate and make these cases for why these initiatives are so important.
We talked a little bit about compliance, educating boards and CEOs, and you didn't learn that in school as a CEO. And like you said, there is no license or certification you need to have as being a CEO, although there probably should be. One thing we always talk to a lot of CEOs about, ever since the Yates memo came out, and I'm sure you're familiar with that, where they're really holding individuals and individual leaders and top people at organizations as well as boards as CEOs really accountable for any liability that they may or may not have taken a part of in a fraud, waste, and abuse situation. And we don't like to cause fear and say it's all bad. We like to look at the positive side of it as saying what's the advantage of having it. But you still have to address the liability that some CEOs have in their part to play, whether it's putting your head in the sand or just telling someone, no, we're not going to do a refund. How do you have that conversation when you talk to a CEO to say, you might have some liability here too? Do you ever have that conversation?
Yeah, absolutely. And it's a necessary conversation because the prevailing belief is that I'm indemnified by my hospital. Right. I'm covered by my contract. I'm well insured. Yet we see more and more leaders, even board members, personally, even board members of voluntary hospitals, personally culpable, responsible, returning money, some doing jail time. So it is real. And again, fear is a powerful motivator, but the exciting thing is the opposite of that is doing the right thing, keeping your patients safe. Hey, I tell people, CEOs and physicians and everybody that'll listen to me, look to your left, look to your right, look up, look down. See all those people, those are whistleblowers.
Right.
And most of that $3 billion in the cumulative money is from key TAM suits. And there's quite a posse out there, and that includes you. Yeah. So if there's something you don't know that you should have known as a hospital leader, and that gets to the standard of leadership if it's going to be tried in court, I'm no lawyer, by the way, I just talk like one sometimes, then you better adhere to the standard, and you're required to know. You cannot be a figurehead. You've got to get into the trenches, and you've got to know it's a broad span of control. But if there's something you should have known, so be hungry to learn if you don't know. If there's something you should have known and something went bad, it's on your watch and you're responsible. You are responsible as a board member, and people are paying the price,
Right.
including your patients. But for you personally, no, there's no one that knows this stuff that will tell you that you're personally protected.
It's amazing because you hit the D&O insurance, you hit I'm an officer here, I'm protected, all these things. And maybe financially at some point in time, I mean, we saw this with the Tenet Group and John Holland matter. I don't know if you know about that issue. CEO of a hospital system that was personally indicted, took away 3 of his houses. And in fact, he had 3 houses, another story. But yeah, and he got personally indicted on his own lawsuits in addition to Tenet. I'm not really sure whatever happened with that one. But at the end of the day, they seized a lot of things. And really coming down to the fact that I occasionally, a lot in the earlier days, CEOs would come up to me and they said, okay, I need a compliance program. I need you to keep me out of jail. And first, when you say that, you're like, do you need to be kept out of jail? What are you telling me? But second of all, it's like the compliance program is not going to keep you out of jail. You have to participate. You have to be a part of this because it is your liability. No one person is going to protect you from any and all things that can happen, civil or criminal penalties. And so that kind of partnership, that kind of collaboration with quality and compliance and clinical compliance and everything else is so imperative so that the CEOs do know that, and board members, and a lot of board members, they need to know that they do have an avenue. They do have the right to ask questions. They have a responsibility to ask questions and get the information so that they can make informed decisions and they can't just put their head in the sand.
And we have at Northgate 80 to 110 projects going at any point in time. And a lot of those are compliance. A lot of those are medical staff. There's a lot of overlap. A lot of them are merger and acquisition, clinical due diligence. And what we know is that a portion of those, probably 5 to 10, are related to working with counsel, either in-house, outside, or both, to keep the human client, the CEO, the board members, the physicians that are involved in the care, to keep them out of jail.
Sure.
And we know that.
Right.
And we're going to always call balls and strikes. We're not a hired gun, but we're going to tell you what you need to know, not what you want to hear, so that you can get on top of it and have the best strategy possible. Let's help you know now, ideally before bad things even happen, help you know now what you don't want to regret that you didn't know until you're in an arbitration hearing with the OIG. Let's know what you can know now. And so, yeah, the best protection is to know. The best protection is to educate yourself. Ross, I have a person who works for me, Ellen. I know you're going to listen to this podcast. Ellen came out of her MHA training.
Okay.
And I've known her since she was a little kid. She was always the smartest kid in the class and very well educated. And she came out of her MHA training and knew nothing. She'd be the first to admit it.
Sure.
And so she came to me and we've had this mentor relationship, and she's really grown up. And now I can tell you, she knows a lot in this world. She's truly an expert, but it's concerning to me that somebody like that could go down a path, and that mentorship, and even early out of school, who you choose to be your mentor is a critical component of what you're going to be and how you set yourself up, not only to protect your community with your fiduciary responsibility, but how to protect yourself too.
And we used to talk a lot about mentors. Mentors are key, like you said, and I've had several good mentors, and a lot of them are CEOs. And one in particular, and we have a podcast on this, Bill Sanger, we were having a conversation and on the podcast, and he said to me, he's like, Ross, I saw you as my executive vice president first and my compliance officer second. And that was quite the compliment for me, because I always knew that as a executive vice president in a very large company, as well as a compliance officer, he exemplified integrity. And I think that was a big thing about how the compliance program was so successful, because not only did he have the business acumen, but he also had the integrity behind it and to do the right thing. And that's when you marry those two, because I've had compliance leaders and not really mentors, but they turned into CFNOs or roadblocks, right? But that kind of experience was really imperative to understand how to do things in a right and with integrity.
Yeah. Just to touch on the mentorship thing, I think about my career, and I was raised, my mother just passed a couple of months ago, and she was instrumental in my life in teaching me about doing the right thing. She's a Holocaust survivor. She has this incredible life, this incredible legacy. We just celebrated her this past weekend. And that's important, right? But you get out of grad school and you still have so much to learn. And most of us that get our MHAs go and do sometimes a summer internship, usually a postgraduate fellowship in administration. For a weird sequence of events, I landed in Champaign-Urbana, Illinois, with Bill Casey. And Bill, I'm going to tell you to listen to this too, because I could not have had a better mentorship.
That's great.
Forcing me to do things that are way outside of my comfort zone. It's quite a story. But he taught me about doing the right thing.
Yeah.
He always stood for doing the right thing. If I were to fast forward, and one of my mentors was one of the CEOs I worked for subsequently, I can tell you that's not the experience I would have had. And I'm not really sure how the subsequent experiences, being ultimately a 26-year-old vice president of a 425-bed hospital,
Right.
how leading up to that would have been impressed and how I would have been shaped.
Right.
Yeah, mentorship is key, and we have a responsibility not only to mentor, okay, but to be the right mentor.
So that liability comes in too,
Yeah.
because you are creating a laundry list. So I think we touched base on this a little bit, and I think you said something like, as a CEO, as board, you need to take a look. You need to take a look at your organization. You need to see where your issues may be. You can't just put your head in the sand. And we talk about having risk assessments and doing that kind of proactive looking underneath the hood and picking up rocks and figuring out where it is. Are there any situations that you've been involved in that you say, oh, you guys could have totally prevented this? I think you talked to a little bit about one of them before we started, was if you would have just done your risk assessment to see where your gaps are in your programs, quality, clinical, compliance, whatever, in addition to those things that keep you up at night, and are you addressing them? How important, or is there situations where something could have been prevented by doing a risk assessment up front?
Knowing what I know, and I think it's part of what makes me a good consultant, is I know what should be expected of department directors and vice presidents. And knowing that, a lot of times I'm asked to do an executive assessment. Sure. And to see the skill level, because that's the in the trenches point in managers where you can keep a lot of this stuff from happening. Do they know the requirements? Do they know the laws? Do they know what to look for? Can they see the blips on the radar? There's a thing the Joint Commission requires, and it's now a commonly used term called ongoing professional practice evaluation, OPI and FIPI focused. But the ongoing is ongoing reconnaissance, and you can do it to meet your accreditation and get an A on your, or you can put it in place to be really meaningful. And I would say in collaboration with compliance, and compliance can have a lot of these very similar strategies. You're watching for things like unexpected returns to surgery. You're looking at over productivity, work RVUs that are off the chart. That's a sign. Maybe things are fine now, but look at the summer of death story out of the Boston area, Manchester, New Hampshire, and there's a fabulous surgeon who did too much, and I think it caught up with while the hospital was asleep at the wheel. Yeah. And I'm not disclosing any confidence. It's all well played out in the Boston Globe by reporters that write way better than I do. It's really effective reconnaissance. But look, if you just look at the outliers, whether it's outliers in terms of work RVUs or money, or in terms of volume of procedures, or if you were to draw a curve for the interventional cardiologist and you look at by procedure code volumes and you say, wow, this practice doesn't look like any one that I've ever seen. What is going on here? Those are the kinds of things that allow you to know or to begin to look. Probably completely understandable. There's a very good explanation for it. This person just happens to be an expert in this area. But you have to have these filters or sensors out there that allow you to identify things at the earliest possible stage so that you can get on top of them. And that area has been, to me, the biggest opportunity, and I preach about it. It's been the greatest way for leadership and compliance officers to know and to identify early so as to save those involved.
It's not that expensive, right? It's not that expensive to data mine. Everybody has what is it called? Not a data room, repository where they're collecting all their data.
It's very sophisticated.
I can't remember what it is. The words are escaping me. It's not that hard to put a dashboard on top of that and just say, who are our outliers? How many is everybody else doing? Where are they at on the bell curve? Are they over here? Are they under here? It's not that hard to data mine and do some utilization. That's what the government's doing. That's what the government's doing every day on every provider out there when it comes to billing, coding, overutilization. Every one of these TPEs, UPIC audits, will say something like, you have been identified as an outlier above your peers within your similar circumstances. And so why don't hospitals and physician practices and group practices, they should be doing the exact same thing. It's not that hard. And when you actually get in there and start having conversations on your risk assessment and talking to people, they will actually tell you, oh yeah, I know, doctors over here, they're way doing too many things that they should be doing, and they're billing them, and they're only choosing Medicare patients, and they're only doing this because the reimbursement is good on blah, 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 blah. And they know those answers. And to your point, look to your right, look to your left. Somebody out there is going to be a whistleblower, because it happens every time.
And don't forget too that you've got to challenge yourself to look beyond what you know. So if your thing is overcoding, because that's what you were taught to look for, you have to look at the documentation that led to the code. And you have to look at the care that led to the documentation that led to the code. You can't just pick a piece out of that continuum and say, we're good. We have seen countless times when the coding is great, only to find out a year later that the issue really was, and you were caught, the issue was that unnecessary care was being provided. So again, you have to have a broad view of all of this as a compliance leader, and step back, learn, call Ross, and take the opportunity to up your game so that you can not only keep your patients safe and you can help improve the quality of care, but you can keep everybody up and down the line safe. And when we promote those programs and we do these things, say, with our physician instead of to them, then what we have is a program that's trusted, it's embraced, and it's one that is, back to the whole ROI thing, stands to be a huge ROI, because everybody involved gets to keep the hard-earned money that we hope was appropriately earned.
Yes.
But let's keep everybody on safe ground. We see people slip to the dark side, and they don't even know they're doing it. Let's help those people. Yeah, there's a big opportunity there, always an opportunity to learn and do better.
Great way to wrap it up. I have one last question, John, and we always say health is wealth, and we are in healthcare for a reason. What do you do to take care of yourself, whether it's mentally, spiritually, physically? How do you stay with it? How do you stay on top of it?
Yeah, one of them is to turn the switch off from time to time. Yeah. The kind of work we all do, it's always in your mind, and you've got to get disciplined about turning that switch off. And for me, that requires distraction. Sure. I play a lot of golf. Good. I cycle a lot. Julie and I love to travel. Those are great distractions, and to have something to look forward to, like the next big trip. Health, diet, those are very important things to keep yourself mentally and physically balanced. One little side plug for all of my physician friends out there is, if you're on a professional football team and you're a position player, you're going to get it all. You're going to get your coaching, you're going to get your psychological coaching if you need it, your financial advice, you're going to get everything as a football player. Our physicians get nothing. Right. They're on their own. So let's also show them some love and put programs in place so that it's safe for them to go and get support. Some places do this well, too many don't. But I think it's more important for our physicians to be balanced than me. Sure. But it's very important for me to stay balanced. I appreciate that and agree with you 100%. Yeah. John, thank you so much for your time today. I really appreciate it. Very insightful. And everybody should go out there and check out Northgate and see how you guys can help. So appreciate your time. Yeah, glad to be here. Yeah, thanks. Thank you for listening to today's episode of the Compliance Advantage podcast. If you enjoyed it, please rate, review, and share this episode with someone who might benefit from it. Don't forget to visit us at ronanhc.com for more resources and connect with us on social media for the latest updates. And remember, compliance pays dividends. Invest today.